So welcome everyone to the evolution of mitral and tricuspid interventions. I'm excited to be joined by Dr. Kim, my co-moderator, and who's going to give us our first lecture on challenging anatomy and advanced techniques in mitral intervention. Dr. Kim?
Thanks for my introduction. Yeah. I would like to talk regarding challenging anatomy and advanced technique. Here's my disclosure. Let me start from the septal puncture. Septal puncture height usually recommend at least 4 centimeter, but there is some issue in this case. This is a recent our case. Well, here is the optimal puncture site, 4.2 centimeter. But as you can see here, there's a bulged atrial septum and very rigid, so it's not so easy to get this height. So finally, we could get a 3.5 centimeter, and the other issue is atrial septal defect was occurred. So finally, we put 3 clips and then fixed with the AS device in this case. The other thing is echo navigation system quite useful to apply the optimal puncture site, especially in fluoroscopy, as you can see here. Also, the other thing is device mitral clip is only available in Korea. The clip device component movement we should keep in mind for the maneuver in some special situation. So here is a very complex and very busy slide, but we can refer to the textbook of PASCAL in this situation. So let me deal with some specific case. Especially first case is anterior septal puncture, or is usually associated with aorta hugger. Then we can apply PASNOB. Then it can be moved away from the aorta of the SCDS, and then we can adjust with M-knob, as you can see here, is 2 more anterior directed position in this slide. The other issue is transseptal puncture too low. So this is a usual situation in Asian population in small lady or a small old gentleman. So SGC rotated counterwise posteriorly and corrected with A knob, and we finally adjusted with M knob. So here is one case, 86 female, very small lady. Here is a severe primary MR, PML prolapse. So this clearly shows PML prolapse, P3 prolapse, and Kodali rupture. But the anatomical criteria were met for the TEER procedure. We did procedure, but one issue is the actual transseptal puncture height is 3.5. So in this case, we applied counterclavicular rotation of SGC to posterior movement and adjust A knob, then moved to the lateral movement, and then finally modified the position of the medial movement with the application of the M knob. So here's the final position is medial part and adequate height of the CDS in LA. So finally, we captured 2 mitral leaflet with the XDW system and decreased the MR grade 1. And the other issue is clip trajectory and clip orientation. Usual clip trajectory here is perpendicular to the mitral valve. However, there is some different situation. Asymmetric tethering of posterior leaflet and anterior leaflet prolapse, then we can use the plus or minus knob, as you can see here, to adjust the trajectory. Also, the other useful technique is a parallax technique in the fluoroscopy. You can match this fourth arm in this fluoroscopy, then you can check the trajectory and perpendicularity in fluoroscopy, especially while advancing into the left ventricle. Also, the other thing is echo navigation system can be applied in this situation. We can mark the optimal position to grasp area with a TEER procedure, as you can see here. Then during the procedure, especially 3D, then we can check the optimal position, and then trajectory, then grasping, then finish the procedure. This is a very straightforward procedure, so we just finished it within 1 hour for this one. With XW, MR was grade 1. And the other etiology of the MR is atrial functional MR. We can apply different types of the mitral clip system, XT or XCW, flattened with enough length of the posterior plate. But NT-W, this situation is very shortened, displaced, and somewhat tethered leaflet, then we can apply the shorter NT or NT-W system. The other very difficult situation is commissure area MR. As you can see here, his reports. So as you can see here, there is a somewhat different strategy according to different anatomy. So, but one of important thing is that we should keep in mind the clip manipulation should be restricted just open and pull up to stabilize the leaflet to grasp, which is very important in this very crowded some Kodali area. And the other is residual MR. There is a two mechanism, mitral valve leaflet perforation and the other posterior clip residual MR. In this situation, it depends on the anatomy and size. We can apply ASO or unplastic vascular plug too. In case of the multiple clips, then at first you should better to apply first clip is a medial position and then lateral position. Then it's also easier to second clip near the central area and second clip positioned as close to the posterior one to minimize the residual mitral valve gradient. Here's one of our case. It's very difficult case because second clip was occurred SLDA. So finally, we did another clip. Between two clips, there is lots of some hindrance of the image. So we checked several times and separately checked the leaflet in this procedure. So finally, we captured this case. So last one is large gap. We can cover with rapid ventricular pacing or just adenosine. Otherwise, it is another important tip to cooperate with anesthesiologist to apply PIV or position change. Here is one case, 78 years male, severe atrial functional MR, as you can see here. But we tried, although we did the 3 attempts, it's not well grasp the mitral leaflet, both leaflet. Then we apply the IV diuretics, reverse transverse position, increase PIV, decrease the preload, and improve the coaptation. Then finally check the intercommissure diameter and enter posterior diameter significant decrease. Finally, we grasp both leaflets sufficiently and shows a significant decreased MR and MDPG 1.8 was a successful result. In summary of my presentation, the optimal location of septal puncture is very important. Understanding function of knob SG torque is crucial for the overcoming special situation. Approach plan and goals are necessary for the difficult case. Finally, we should keep in mind close cooperation with imaging specialists and anesthesiologists is essential for overcoming difficult cases. Thank you for your attention.
That was an excellent talk on the multiple considerations required for mitral clip insertion. I think you want to introduce our next speaker?
The next speaker is Shunsuke Kubo, and he will talk how to prevent and manage procedural complications during TEER. Shunsuke, please.
Thank you, Jensen. A kind introduction. So, you know, there are various complications during the TEER procedure. I think the transcatheter puncture, one of the most serious complications is the cardiac tamponade. If we insert the guide catheter, we can see some complications, including the brain injury, air embolization, and the pulmonary vein injury. The timing of the leaflet grasping is a very important complication, the single leaflet device attachment, the leaflet tear. And when we remove the guide catheter, we can sometimes see a right to left shunt and acute right ventricular failure. But my talk mainly focused on the leaflet grasping. So in the transcatheter puncture, we can really observe the cardiac tamponade. In this case, we can puncture the posterior part of the septum, but after removing the guide cutting, you can see the pericardial effusion. So TT reveals the pericardial effusion. So I think that this puncture is punctured the part of the atrial maxilla. So but the solution is very simple. So don't move the needle if image cannot be obtained. Don't puncture the atrial wall, and also we should puncture within fossa ovaris. I think that we can do the mitral clip procedure if the height from the tenting to annulus is more than 30 millimeters. So we don't need to puncture out of the fossa ovaris. When we leaflet grasping, we can see a very important complication, single leaf device attachment and leaf tear. But there are some reasons to occur the complication. In this case, we implanted the MTW for the P3 flake. But as you can see, the leaflet insertion is not reliable at the timing of the grip down. But MR reduces, so we finish the procedure, but the next day you can see the single leaflet device attachment of the posterior leaflet is stripped off. So I think that this complication is occurred due to the insufficient leaflet visibility of the posterior leaflet at the timing was grasped down. Here is a leaflet tear case. So we implanted just empty grip, the ventricular function MR with the posterior leaflet tethering. So after the grip are down, we're closing the clip, but as you can see, the posterior leaflet is not restricted. So after opening the clip, we check the leaflet. As you can see, the new eccentric MR from the mid portion of the posterior leaflet. This indicates the leaflet perforation, but this is occurred due to I think the huge tension to the leaflet. So, to prevent the SLD at the leaflet tear, we should secure the gripper down, and we can use the CZA for the just leaflet insertion confirmation. And so this movement is to improve the leaflet visibility. So now, we also that we should grasp only one time, so minimize the grasping time, and also that we should slowly close the clip to reduce the tension to the leaflet. So here is some examples of the gripper down. So we should check here. So leaflet is touches at the base of the grip arm. So we should stop the hand before the gripper down to confirm how much leaflet in the grip arm. So after that, so we should slowly put the gripper down, keeping both leaflet on the arm. So if possible, we should grasp without CZA system, independent grasping. So non-central MR is a little bit challenging because the clip orientation is like this. So sometimes the counterclockwise and sometimes the clockwise to coaxial to the coaptation line. So in this case, we counterclockwise the clip orientation. So we should adjust the TE angle of the LVOT image. So if we turn the counterclock a little bit, so we should reduce the TE angle a little bit. This is under commission for us. We should put the clip like this. So it's also a counterclockwise orientation. So we should reduce the grasping angle of the LVOT like this. So when we use the CZA, so minimum maneuver is recommended for the final adjustment. In this case, the grasping posterior leaflet is a little bit challenging, so we grasp anterior leaflet first, and after the confirmation of the orientation, we just move to the posterior a little bit and grip it down. So we recommend to use the final adjustment of the tissue insertion. But the CZA is also can be used for the leaflet insertion confirmation. In this case, due to the arch factor of the shaft, we cannot see the posterior leaflet well. So we check the posterior leaflet to see that from the medial side in the X-plane beam. So and after that, we check the anterior side from the lateral side. So, if the both leaflet cannot be visible in the same time, so CZA is effective for the leaflet insertion confirmation. So also that we should should close the clip slowly to minimize the tension. In this case, we implanted the XCW clip with CZA. So after the grip are down, we should erase the color, and we should focus on the posterior leaflet, and at the same time same time of the closing a clip, we should release the tension by pushing the clip to the LV. After completely closing the clip and reduce the tension, MR is assessed by the color Doppler. So sometimes we can see the leaflet tear like this. So in this case, we put the NTW, but after fully closing the clip, you can see the newly eccentric MR. And after opening the clip, we can see the leaflet perforation. But as you can see, the perforated part to the tip of the leaflet is about 5 millimeters. So we think that we can cover this perforated part by the XCW clip. So we converted the XCW clip and fully cover the leaflet and the perforated part using the XCW clip. After closing clip, the perforated part is completely covered by the clip. But now we can use the PASCAL device. So PASCAL device is a very flexible nitinol frame, and we have a central spacer, so we can reduce the tension on the leaflet compared to the mitral clip device. So also this device can elongate the shaft, so we can reduce the risk of the cord entanglement. This is a the complex case. We can see the mark and very fragile posterior leaflet prolapse. So we decided to use a PASCAL device in this case. So as you can see, the posterior leaflet with the mark was grasped with the posterior paddle. So after the closing clip, so nitrile system with the spacer limits the tension to the tension on the posterior leaflet and reduce the risk of the leaflet tear and also the mitral stenosis. This is my conclusion. Thank you for your attention.
Thank you for a nice lecture, and it's very educational. Yeah, some summary of the complication during the TEER procedure. Next speaker is Shinichi Shirai, Gokura Memorial Hospital. He will talk regarding new launched M-TEER device for degenerative mitral regurgitation, PASCAL experience in Japan. Shinichi, please.
Thank you very much. So, good morning, everybody. So, already Shunsuke presented the PASCAL device. So, and I will a little more detailed procedure of the PASCAL device. This is my disclosures. So this patient is a 79 years old woman, severe MR due to P2 prolapse. And a younger patient, but she is steroid users, erythema and a history of lung cancer operation, and primary sclerotic cholangitis, and no cognitive dysfunction. So we choose the M-TEERs using the PASCAL like this. This is the P2 prolapse. Here you can see. And pre-TEE, previous procedure TEE shows the huge regurgitation from the P2 prolapse portion. So ER was also 0.76 centimeters squares. And this is a PASCAL precision transcatheter valve system. So, and guys, sees handle just like other companies, SCC, and the steerable catheter handle is like this, and so implant catheter handle. So, and steering down the mitral clip and the some manipulation of the clip's arm. So then in order to grasp the clasp, so with the implant catheter. So each handles have some each procedural plan. So, and this is, as you, Dr. Shunsuke said, two types of the PASCAL. So what PASCAL ACE and the PASCAL P10. So in this case, this patient is prolapse and the longer arm is needed. So this we choose PASCAL ACE and we not PASCAL P10. We don't have any experiences, but Dr. Shunsuke have already. And this is the septal puncture. It is the same for the mitral clip and a 40 centimeter height. And fortunately, this device is very easy to penetrate the septal portion. So in other device, it's a little bit difficult and or violently passing the septum. But this device is very easy to passing through the atrium. So, and the implant system insertion, so a little bit the longer device, because elongated position, the device was inserted into the LA elongated position. Then we need to shortening the device. And then insert the clip. So, but the one step is usually omitted because so the device should be parallel to the mitral valve, but we skip usually. And usually this steerable catheter handles the turning the knob, so and going to the mitral valve. So compared with other systems, so M knob with posterior guide catheter is needed to steering down to the mitral valve, but this device only rotating the knob is needed to mitral valve. And trajectory and the PASCAL insertion is the same as the previous one. And using this portion implant catheter handle manipulating and paddle opening and grasping and not the grip, clasp down like this. But closing the paddle. A little bit not completely grasping the posterior reflex, so we need try to reclasp only at the grasp posterior side. And then independent re-grasping and the posterior reflex side. And opening, and posteriorly toward, and then down the grasping. And closing the paddle. And this is just after the grasping. And this is the final result of the detaching of the paddles. Discussion. And this is a procedural early pressure, but just after the paddle procedure, so post-procedural early pressure was remarkably down. And there's no residual mitral stenosis, and PV flow was excellently improved. So this is the conclusion. So we experimented a fast PASCAL race implantation for P2 lateral prolapse in Japan. So guide teeth was excellent to penetrate the access site and the septum because of the seamless structure of the outer and the inner teeth. PASCAL system had an ergonomic handle to manipulate in the procedure. Although there are some differences, the structure is like that of the preceding product. It is also expected that the learning curve would be first due to familiar with the treatment techniques. So compared with preceding product, in PASCAL, MV area loss will be less because of the spacer, and the device number will be saved due to the width of the puddle. Thank you for your attention.
Thank you, Shirai. Yeah, it's very educational lecture for the PASCAL system. But unfortunately, it's not available in Korea. We are expecting another system only available in Evo system until now. Is there any question for this mitral procedure? It's just, I think we have 10 to 12 minutes.
Yeah, I have a question for the last presenter. Excellent presentation. Now that you have experience with the PASCAL device, are there certain anatomies or situations where you will favor that over the mitral clip, or what's your algorithm to decide which device to use?
Yes, so now we are searching the device because recently the device was introduced in December, last year December, and only degenerative. So in Japan, that 70% of the mitral clip indication is a functional removal, and the degenerative is less than 30%. So now we are searching the differences and what is the most appropriate anatomy is searching. But this patient and one desirable anatomy is a small MVA patient with prolapse. So mitral clip usually causes the mitral loss of the mitral valve area, but this product is the spacers, so it is a less loss of the mitral valve area, maybe. But do I have any preference?
Yeah, so I feel that now so Dr. Shirai says the PASCAL can be used for the primary mark only.
Yes.
But personally, I use the PASCAL to all come out with the primary mark. So I think that the non-central region is good because due to the elongated system. But you know that the device is a little bit larger than compared to the mitral clip system. It is sometimes difficult to the very narrow commissure region. It is a little bit difficult to insert the device to the very narrow space. So, and also that it is easy to do the multiple clips using the PASCAL device. So because due to the elongated system. So if we feel that this anatomy needs a multiple clips, so I think the PASCAL is also more favor. And also the Dr. Shirai says that it's a good for the small MVA. Actually, our Japanese population, around 20 or 30% of patients has a valve area less than 4 square centimeters. So it's due to the sensor system, and I think that after the closing, the PASCAL devices are not so tight. So I think that's why it's less risk of the mitral stenosis.
And I think you showed an example of a commissural lesion where, in my experience, there's less entrapment of the device as you try to make multiple bites at it. So it seems like it's a little safer for some of that treacherous anatomy.
What other situations do you like the PASCAL over mitral?
Well, you know, if there's borderline height, you think you're going to struggle for a medial lesion, and you know, I think the 3.5 is plenty of height for the PASCAL, whereas with the mitral clip, it may be pushing it.
Yeah, the other one that was a nice example. By the way, the imaging was beautiful on your lectures, really. I should get that imaging. But the calcified annulus, yeah. I think that I wouldn't do that with a mitral clip, but I think that the PASCAL works very well there.
I agree.
Yeah.
I have a question for the speakers. So with the advancements in the device and the techniques, is there a certain subtype that you feel is completely prohibitive for a mitral TEER procedure? That's the first question. And the second question is to Dr. Kubo. You mentioned the height, that you're more comfortable with the shorter height nowadays. You know, what's truly your sort of comfort zone in terms of the puncture height for?
I think that the most of the patient with mitral regurgitation is I think that the treated can be treated by the TEER procedure, but only issue is the stenosis. So I think the very small MVA, especially less than 2.5, is tough to treat it by the TEER procedure. And so you know in the Japanese population, very small heart. So around the 3.5 centimeter is very not unusual, very common. So I think we are very familiar to use the A knob, and also we adjust the puncture. I think that I like I think also Dr. Shirai likes a little bit inferior puncture, because you know the superior puncture is tend to be an outer Haga trajectory. We should use a plus knob. So plus knob we lose the height. So that's why we like to puncture the mid to inferior and posterior. So we can sometimes use the minus knob. So minus knob, we can gain the height. So in these, using these tips and tricks, so we can gain the height. But you know, James says that I think that the PASCAL device is easy to gain the height because we have two components to gain the height: the guide catheter and the middle device. So now so it is more easier to gain the height by the advancement of the device and technique.
So you already mentioned between two devices for the septal puncture height. So in the PASCAL device, what is the limit to perform the procedure?
Yeah, but so I say that the enough puncture height is always better.
Oh, yeah.
Yeah, the 4 centimeter is always good.
So one tip I wanted to share that I just came up with a couple of weeks ago. We were in a case, we had a lot of shadowing, and we couldn't see the anterior leaflet. We were using a PASCAL device. And so what I did was to, it was perfectly right down the middle, but that catheter shadowing, we couldn't see the leaflet. So I made it an aorta hugger, just a little bit. I just tilted it over a little bit, and it completely opened up the visualization. It was very helpful, and I think, you know, it's I won't call it dangerous, but it's difficult when you're in the procedure. You don't know that's what's going to happen. You don't know that kind of thing is going to happen anyway. So that having a workaround is very useful. A couple other comments I had is we optimize pretty frequently. So we optimize. We open up. We figure if it's not in there, it falls out. It never was in there in the first place. So we optimize pretty much in every case. We swing to the posterior, swing to the anterior, and we make sure in each case that there's a good leaflet insertion. So we have rare SLDAs these days. I don't know if other people do that routinely or not.
Well, the nice thing with PASCAL is you can move to that side before you optimize. You don't have to.
Yeah, you do that with the mitral clip too.
You can, but it's a little trickier because you might.
But I think
pull it up.
that's really useful, and I think it's something that really should be built into the procedure, I believe, because I think it's important, no matter how much you thought you got on a double capture.
At least cycle the paddles with the grippers.
Yeah, the whole thing. I mean, it's better.
Yeah.
So in terms of the grasping, so how is the very best way to evaluate the adequate some capturing of the both leaflet? Because sometimes, as you already know, we just depends on some imaging. Do you usually check some ranks of the capturing or other? Is there any object way, to evaluate that kinds of things?
Your question about how to optimize the leafleting session?
No, just a check how to evaluate.
Evaluate the
Just a
leafleting
T.
session.
Usually you evaluate by T,
Yeah.
but it usually depends on some imaging.
Yeah,
But sometimes the image is sometimes good, sometimes bad, sometimes some very obscure. So sometimes it is not so easy to evaluate appropriately whether this leaflet is captured appropriately or not. So
yeah, it's depending on the images.
Well, so I think, there's some indirect ways of doing it, right? There's two indirect ways. One is to look for the tissue bridge on 3D.
yeah.
And the second way is actually to measure the pre-existing leaflet length prior to the clip implant, and then measuring the residual leaflet length, and you know how much is in there. So for instance, in a clasp PASCAL, you have 9 millimeters of insertion length. And if you can do the math, you can figure out whether you have enough.
The other thing that you were alluding to is you don't want to be completely closed when you assess your leaflet grasp because you'll get fooled. So maybe 60 degrees or cycle them, as Dr. Gray said. Then you can see the leaflet and make sure that it's actually on the grasper or the paddle or whichever device you're using, and feel comfortable that it's in there. If you just crank it all the way closed, you may not have as much as you in and it may slip off.
Yeah, I completely agree. So after fully closing, we cannot see the leaflet, and we cannot assess how leaflet is in the clip arm. So before the closing the clip, I think I usually check the before the closing. So if we tie the closing tie to the clip, yeah, it's difficult.
Can't tell.
But and also okay.
Okay, this has been a really great discussion. I could do this all day. I'm a little bit of a mitral nerd. But we have to move into our next session. We're going to do tricuspid, and I'm pleased to introduce recording by my former colleague and partner at Columbia, Susheel Kodali, who's going to speak to us about the TRISCEND 2 transcatheter tricuspid valve replacement in patients with severe TR. Can we roll that recording, please?
Hello, and thank you for the opportunity to present the results of the TRISCEND 2 trial. Here are my disclosures. Although historically underappreciated, the importance of severe TR in leading to debilitating symptoms and poor outcomes is being increasingly recognized. Treatment options for severe TR are limited, with medical therapy being suboptimal and surgery having high rates of morbidity and mortality. There is clearly an unmet need for transcatheter solutions that provide treatment options at lower risk and result in improved outcomes for this challenging patient population. Here is a look at the Edwards Evoque valve. It consists of a nitinol self-expanding frame with a bovine pericardial tissue valve. The valve anchors into the tricuspid annulus via 9 ventricular anchors, as well as annular oversizing. In this initial trial, it was available in 44, 48, and 52 millimeters. All devices were delivered via 28 French transfemoral delivery system. The TRISCEND 2 study was designed as a 2-part study based on the FDA breakthrough designation. The first 150 patients randomized and treated, there was an initial look at the primary safety at 30 days and effectiveness at 6 months, including TR grade reduction and a hierarchical composite of functional status improvement. The entire cohort of 400 patients is already enrolled and follow-up is ongoing. The primary endpoint at the 400 patients is a hierarchical composite including important clinical outcomes such as mortality and heart failure hospitalizations, as well as improvements in functional status. So we're going to take an initial look at the first 150 patients, which was presented at TCT last year. The TRISCEND 2 study was a randomized trial. All patients were screened and enrolled by an eligibility committee that was independent from the individual sites. Once eligibility was confirmed, they were randomized 2-to-1 to receive Evoque or continue on medical therapy. They were followed at 30 days, 6 months, and annually out to 5 years. There were multiple important inclusion-exclusion criteria, but key exclusion criteria included severe RV dysfunction and severe pulmonary hypertension, as well as anatomy unsuitable for placement of the Evoque valve. The primary safety endpoint was a composite endpoint with the individual components shown here. All events were adjudicated by an independent CEC, and the composite MAE rate was compared to a pre-specified performance goal. As there was no predicate trial, the pre-specified performance goal was derived from an MAE rate following isolated tricuspid valve surgery. This was from a Medicare fee-for-service claims database, and you look at the individual components. After eliminating the ones that were primarily related to surgery alone, the expected MAE rate was felt to be 43.8%. The two co-primary effectiveness endpoints at 6 months included TR grade reduction to moderate or less, and the second was a hierarchical composite endpoint including improvements in KCCQ, NYHA, and 6-minute walk distance. This was compared to between the two arms using the Finkelstein-Schoenfeld method. Here is a look at the baseline characteristics. Mean age was around 79. Majority of patients were female. Mean KCCQ was less than 50, and all patients were either very high risk or inoperable for surgery. Nearly all patients had atrial fibrillation at baseline. The only difference in baseline characteristics between the two arms was stroke, which was higher in the evoke arm. And importantly, more than 40% of patients had a pre-existing pacemaker at baseline. The majority of patients, nearly 3/4, were secondary TR, and more than 50% had massive or torrential TR at baseline. Here's a look at the procedural characteristics. The valve was implanted successfully in 96% of patients with a mean device time of 65 minutes. All procedures were done via percutaneous access, with the majority from the right femoral vein. There was 2% of patients that underwent convergent surgery. Median length of stay was 4 days, with more than 90% of patients being discharged to home. The primary safety event rate was 27.4%, with an upper bound of 36.9. This was less than the expected MAE rate of 43.8%. Here is a look at the individual components of the safety endpoint. 10% of patients had severe bleeding, and 14% of patients had an arrhythmia requiring a new pacemaker. Cardiovascular mortality at 30 days was 3%. In terms of TR reduction, the evoke valve got to moderate TR in nearly 99% of patients, and nearly 94% of patients had mild or less, which was significantly different than the patients in the control arm. If you look at the functional status improvement using the Finkelstein-Schoenfeld, patients that received evoke had a significant improvement in functional status at 6 minutes as based on improvements in KCCQ, NYHA, and 6-minute walk distance. Another way to look at this is to calculate a win ratio, where each patient is compared to every other patient. And if you look at this and look at the individual components, you see them listed here in a hierarchical fashion. And if you, in the evoke arm, the majority of patients had a better outcome, and the win ratio was 4.6, which suggests they're this much more likely to have a better outcome if they receive TTR with evoke compared to medical therapy. Now, this is a look at the initial 150 patients. As I said, the 400-patient cohort is enrolled, and follow-up is ongoing. But based on the FDA breakthrough designation, the FDA was willing to look at all available data when they met to look at the data earlier this year. And this is what was put out by the FDA document in February of this year. And you see here more than 300 patients, nearly 320 patients had already received 1-year follow-up. And so using this cohort of patients that already received 1-year follow-up, the FDA calculated the 1-year hierarchical win ratio, which included mortality, heart failure, hospitalizations. And what you see here, patients in the evoke arm did significantly better than the control arm, with a win ratio of 1.74, which was significantly better than the control arm. Here's the Kaplan-Meier curve, and again, this is not the entire cohort, but what you see there is there's initial risk with evoke, but on 10 months, the lines cross. Although not significant, you see the mortality is numerically lower in the evoke arm. And also the individual components of KCCQ, NYHA, and 6-minute walk distance were all better in the evoke arm compared to medical therapy. So this early risk was offset by late benefit. They also looked at the echo data, and all available echo data, and you see the numbers here. And it showed that patients that received evoke had improvements in RV stroke volume and decrease in RV dimensions compared to the control arm. And you see this highlighted here. So this initial look of the 150 patients at TRISCEND 2 demonstrated that TTVR with evoke is feasible with an acceptable safety profile in a highly comorbid population. It also demonstrated that TTVR with evoke effectively eliminates TR in the vast majority of patients, reducing to mild or less in nearly 94%. And this treatment with evoke resulted in meaningful improvements in functional status and symptoms at 6 months. The initial look at the 1-year data showed that TTR evoke has potentially meaningful improvements in important clinical outcomes, including mortality and heart failure hospitalizations. Although the full cohort of data is not available on the full cohort, and this will be presented later this year, the initial look at the totality of data suggests that TTVR with evoke has benefits over medical therapy. And based on this initial look at the data, the FDA gave approval for the evoke system for treatment of patients with severe TR that were very symptomatic on February 1st of this year. Thank you very much for this opportunity to present, and I look forward to an exciting discussion.
Thanks for nice lecture, Susheel. Our next speaker is my co-moderator, William Gray. he will give a percutaneous tricuspid valve intervention, multiple option to benefit patient outcome. William, please.
Thank you very much. I'm actually going to continue a theme, and I'm going to try to not step on David Cohen's next talk. But as you're going to see here in randomized data as well as in single-arm data, that what we're seeing primarily in the tricuspid space is a significant and meaningful improvement in patient outcomes, which is the title of the talk. So just a couple of minutes on the pathophysiology of functional TR, which accounts for 90% of tricuspid regurgitation. Here's a normal tricuspid valve, and what we know is that the septal leaflet here does not move. It's anchored to the septum, but the lateral wall of the RV moves away, and it drags the anterior and posterior leaflet, the lateral leaflets, away from it, and that creates a coaptation gap. And in addition to that, we see a change in the morphology of the valve in later stages where it flattens out from its normal saddle shape. And we know that the prognosis of untreated tricuspid regurgitation is very poor. We treat it with medicine, but as we've learned in medical school, valvular heart disease is not a medical problem. It's a mechanical one, needs a mechanical solution. And regardless of how you define the patient populations, you see that as ranked by the severity of tricuspid regurgitation, frankly, in older categorizations of tricuspid regurgitation that didn't include massive and torrential, that all of the data suggests fairly strongly that there's a significant reduction in mortality, increase in mortality with worsening TR. Surgical outcomes, unfortunately, have been historically poor, and a lot of that probably has to do with the fact that patients were sent for isolated tricuspid surgery late in the course of their disease. You can see here that tricuspid valve surgery, whether it's replacement or repair, has increased a bit, but not really materially over the last decade or so when data was available. And whether it's repair or replacement, you can see that it's relatively infrequent in the STS database. And if we look at in-hospital, just in-hospital mortality, not even 30-day, we can see that for both repair and replacement, mortality somewhere between 8 and 12%. Now, I will tell you that in our experience post-percutaneous research, we see patients in the earlier stages of tricuspid regurgitation, and those who do not qualify for percutaneous approaches actually are quite good surgical candidates and do reasonably well. The surgical predictors of in-hospital mortality included coagulopathy and comorbidity indices, which again speaks to the late presentation. So enter the TriValve registry. There's actually two components to this registry. Most of it related to the mitral clip, meant for the mitral valve, but used in the tricuspid position. Many of these other devices are no longer available, actually, being tested. And there was a significant reduction in tricuspid regurgitation, a very early kind of frontier-like experience. And we see that if you had procedural success, you did much better in survival as opposed to patients who did not have any procedural success in this early experience. David's going to speak extensively about TRILUMINATE. I'm not going to step too much on I hope not to step too much on him, but I just wanted to talk about this a little bit. This is the results published in the Journal of Medicine and presented already. We did have a single leaflet device detachment of about 7%, not too bad in a large multi-center trial. And we can see a very effective TR reduction with the mitral clip as compared to control, with 87% of the patients having moderate or less tricuspid regurgitation. And it turned out to be a positive study with a win ratio favoring intervention. And again, I'm not going to step on David because I want him to be able to speak to this. But I do want to talk about two other systems here. One of them is the PASCAL transcatheter edge-to-edge repair system, and we've already heard about this. Actually, the most frequently used here is the PASCAL ACE. I'm going to show you data from the early feasibility study that primarily used the PASCAL platform, but now that ACE has been developed, it's really the go-to device for tricuspid intervention. In the early feasibility study data set, at 6 months, 42 patients were available for evaluation. And you can see of the 63 that were enrolled, as in the EVOKE trial, you can see that most of them are in atrial fibrillation. And that's important because many of them are anticoagulated, and many of the safety events are bleeding, unrelated to the device, actually. And in this early US experience, you can see that implant rate was quite good, actually, 91%. And most of these patients, as I said before, had PASCAL, which I think is a suboptimal device for this. Event rates at 30 days and 6 months were quite low, although bleeding was present and probably the most frequent adverse event. And SLDA rate was about half, maybe a little more than half of what it was in the TRILUMINATE study. And we see significant, and this is thematic now, you're going to see this in multiple trials, but we see significant reductions in TR, PISA, vena contracta. We see significant improvements in the NYHA, 6-minute walk. It does improve at the beginning and then kind of flattens out. And then KCCQ scores also increase significantly in a single-arm study. And the last system I want to talk about is the tricuspid cardioband system, which right now is on hold, awaiting a third-generation iteration. It actually recapitulates a surgical predicate, which allows for us to put a ring, basically, in the tricuspid valve and draw it in under real-time echocardiographic analysis. You can see here that there's a lot of planning that goes into the cardioband. This is a rendering of the right coronary artery, the anchors that are anticipated to be placed, the band length, and their proximity to the right coronary artery. So it's actually pretty important planning. You'll see here that we use fluoroscopy, we use TEE, a lot of M-TEER. We have to look at the hinge point for the valve right in here to place that anchor. Many times, especially in certain portions of the valve at the acute margin, we'll use the ICE catheter to see better the implantation hinge point. And I was privileged to be the PI for this trial. This is the 1-year data set, and you're going to see here, again, very similar result, demographics to the TRILUMINATE study, a lot of atrial fibrillation and flutter. Device success, actually, let me go back there. The device success was excellent at 92%. Unfortunately, it took over 3 hours to put the device in, and that's what the engineers are working to fix in the next iteration of the device. We see that reintervention was relatively infrequent. There was a lot of bleeding, but most of it was not related to the procedure. But these patients are old and they had a lot of anticoagulation. Here's the freedom from, here's the Kaplan-Meier estimate of survival. Pretty good, but uncompared to a control. And we see the freedom from heart failure hospitalization really flattens out at about the 6-month mark. And again, thematically, a lot of improvement over the course of the ensuing year, which is sustained, and we see improvements in paired analyses in TR severity across the board in all metrics. I'm not going to go through all that. And we see quality of life indices also majorly improved at 1 year. Again, 6-minute walk test doesn't really meet that metric. So in summary, medically treated severe TR has a poor outcome. Surgical approaches have been classically associated with higher than acceptable mortality, and multiple approaches to address severe TR have been developed. Now 2 completed randomized trial versus optimal medical therapy, and 1 further randomized trial, the class 2 TR, completion is imminent. These are likely to be the last randomized controlled trials against medical therapy. The next will likely be against either a performance goal or an existing approved device. And all studies generally demonstrate good safety profiles, sustained efficacy in TR reduction at 1 year, and improvements in patient-reported outcomes. And the results are remarkably consistent across devices. Thank you very much.
Thank you for your comprehensive review of the tricuspid annuloplasty strategy. So next speaker is the last speaker of this session, and David Cohen. Health status after transcatheter tricuspid valve repair in patient with severe tricuspid regurgitation. David, please.
Thank you very much. My pleasure to bat cleanup here in the session. So by way of background, we know the main results of the TRILUMINATE trial. There were 350 patients randomized in the pivotal phase. There actually were a total of about 580 patients randomized that were reported more recently. But we're going to focus on these 350 patients who were reported in the New England Journal of Medicine, and the main study showed substantial reductions in TR, no differences whatsoever in death or heart failure hospitalization at 1 year, but a significant improvement in the patient-reported outcomes as measured by the KCCQ, including symptoms, functional limitations, and quality of life, and these are what drove the primary endpoint and led to FDA approval of this device. And as we reported last year at the TCT meeting and subsequently published in JACC, we performed a very detailed analysis of the quality of life in order to understand several things. First, to understand the magnitude as well as the durability of benefit. Is this a relevant amount of improvement? To see whether there were any factors that where there was heterogeneity of treatment benefit, some patients who benefited more or less. And then finally, and probably most importantly, given the unblinded nature of the study, to try to determine as best we could whether the quality of life benefit is truly biologically mediated or is this all a psychological phenomenon. So the study design, as you should be aware, it's a multi-center open-label randomized trial in patients with severe or greater tricuspid regurgitation and symptoms. There were several groups of patients who were excluded, who had untreated other cardiac conditions. The health status was assessed at several different time points, and the primary instrument was the increasingly familiar KCCQ. This is a heart failure specific scale, which we have actually now validated for tricuspid regurgitation. The scores range from 0 to 100. Higher scores are better, and the minimum change for an individual that's important is a 5-point change, which has been 5-point difference, which has been well established. The primary endpoint was the overall summary score. We also collected some more generic measures, the SF-36, which are general measures of physical and mental health. And these scales, 50 is the median in the United States population, and the standard deviation is 10. A minimally important difference is about 2.5 points. In terms of the baseline health status for the patients, you can see here the KCCQ overall summary score is in the mid-50s. This is similar to actually what was seen in the COAP trial with tricuspid regurgitation and in the Partner 2A trial with intermediate risk patients undergoing TAVR. So these patients are moderately impaired. They're kind of largely in New York Heart Association class 3 based on the KCCQ scores. You can see they had substantial physical limitations with a score of 35 compared to the US median of 50. They did not have very much in the way of mental depression or anxiety related to their heart condition. The primary endpoint was the KCCQ overall summary score. Here is the control group. There was a small improvement, about 5 points compared to baseline, and then the scores stayed stable over the next 11 months. In the treated patients with the TriClip, there was a substantially greater early improvement, and that benefit was sustained really without attenuation out through 1 year, with a difference between the control and the TriClip patients of about 10 points, which is a moderately large difference, and we'll talk more about that in a few minutes. In terms of the other scales, the SF-36 physical summary also showed substantial benefits with a benefit of about 4 points at 1 month, and 5 points, which is substantially larger than the clinically minimally important difference at 12 months. And then for the mental summary score, they did not start very impaired. There were small differences, but these were not at all statistically significant. What about subgroup analyses? Were there any patient characteristics that differentiated those patients who benefited more or less? You can see them all summarized here in a typical forest plot. And largely, there were no significant interactions for age, for sex, whether they'd had previous treatment of aortic or mitral valve disease, some measures of right ventricular function. None of these seem to differentiate who benefited more or less. There was one subgroup shown here when we start to get to the hemodynamics, patients with a very low cardiac index at baseline of less than 2 liters per minute per meter squared, which was a small fraction of the patient population, did not seem to get much benefit, whereas patients who had a relatively preserved cardiac index seemed to derive the vast majority of the benefit. That was a borderline statistically significant interaction. But the really important interaction and the real take-home message here is with the baseline KCCQ score, which you would imagine would be the case, and we did find this. This shows the relationship between the baseline KCCQ score and the amount of improvement. The bright blue line is the mean treatment effect, and then the shaded lines are the confidence intervals. And what you can see here is for patients who were substantially impaired at baseline with scores between 0 and 40 or so, there was at least a 20-point improvement. As that baseline score tended to increase, the degree of improvement became less. And when you get to around a score of about 80, you can see that there was no statistically significant difference after the TriClip. So there certainly seems to be a relationship, very strong interaction test here. In terms of how to interpret these results, one way that we like to describe these to help us understand and get some intuition around whether these improvements are important is to categorize the outcomes. And so shown here are 3 different ways of categorizing the KCCQ outcomes. This is the proportion of patients who are alive with a moderately large improvement of 10 points or more. Then in the middle is alive with a large improvement, 20 points or more. And then finally, a value we call alive and well, which means that their KCCQ score was at least 60, putting them into New York Heart Association class 2 or better. And they were still alive, and their health status had not declined by at least 10 points. You can see, regardless of the way that we slice the data, there is a very large and clinically important difference between the 2 groups, with number needed to treats in the range of 3 to 4. So a very favorable number needed to treat in order to achieve clinically meaningful improvements. So the final point that I want to come to, and again, in some ways the most important, is the idea of whether this is biologically mediated or not. And for this, we did exploratory analyses. We restricted these analyses to patients who received T-TEER, patients who got the TriClip, in order to try to take the placebo effect out, because all of these patients were treated. And the first thing we looked at was the relationship between the change in the KCCQ and the change in the TR grade between baseline and 1 year. And what we saw in this analysis after controlling for other covariates is that for every 1 grade improvement in tricuspid regurgitation grade, there was a 4-point improvement in the KCCQ, which means if you think about it, if you had a patient who started out with torrential TR and they went down to moderate, that's a 3-grade improvement. We would expect on the basis of these data that they would get about a 12-point improvement in their KCCQ, which is a moderately large improvement. So this gives us some intuition, but it shows us that there is a biologic relationship here, what I like to call a dose-response effect, which indicates, again to me, that there is something biologic more than just psychological going on. Similarly, we looked at the association of the change in the KCCQ among patients who underwent tricuspid clipping at 1 month, and then the association of the relationship between this and subsequent events. And what we saw here is, regardless of which event we looked at, whether we looked at death, whether we looked at heart failure hospitalization, or the composite of death and heart failure hospitalization, those patients who improved the most at 1 month had the best outcomes with respect to clinical benefits. So again, this points to the fact that these patients who are experiencing changes in their KCCQ are experiencing some obviously biologically relevant changes in their health. So to summarize, in patients with severe TR, T-TEER provided substantial benefits in terms of symptoms, functional status, and quality of life. The difference in health status between the 2 groups against the control group was moderately large. It was fully evident by 1 month, and it was sustained through 1 year. There was a strong treatment interaction with baseline health status. The patients who were in the worst shape, who had the most symptoms at baseline, were the most likely to derive a large benefit. And finally, the exploratory analyses that I just described suggest that the observed health status benefits are at least partially biologically mediated, although I would not, I would not say we are, certain that there is no placebo effect at all here. So in conclusion, our belief is that these findings support the use of tricuspid TEER with the TriClip device for improvement in symptoms, functional limitations, and quality of life in patients with severe TR, and this is exactly what the FDA agreed with and is the indication for tricuspid TEER at this point. Thank you.
Dave, maybe you could join us up here for questions. You're not getting away that easy. Excellent discussion, very clear, presentation, very clear. Susheel, welcome. Can you hear us okay?
Thank you.
Yeah.
Yes, I can hear you. Can you hear
And
me?
your presentation was wonderful too. Let me just start with you, Susheel, and then I want to open the floor up to everybody. When can we expect the 1-year data? I know that's it's burning on everybody's mind from the TRILUMINATE, from the EVOQUE trial.
I think later this year, and I think, we're all waiting for it. We're starting to see the trends. I think part of the challenge is we really want to see those outcomes, heart failure, hospitalization, mortality, all these things. And we're starting to see trends. And I think, David's analysis shows that as well. And I think, if we can eliminate TR, we take sick patients, those are the ones that are really going to be beneficial. And I think with a lot of these early trials, what we need to understand is this is such a heterogeneous population. The disease state is really sort of variable from secondary to atrial functional, that we need to be able to better select. And I think these data sets are going to help us understand who's going to benefit. And I think we're sort of at that early stage, and hopefully these more complete data sets will help us understand who to treat and how much benefit we can expect.
Great, we have a question in the audience. Sir.
I have a question to Dr. Kodali. Congratulations for your very successful TRISCEND 2 trial. But we all know that the right cardiac chambers are low flow system. Do you have evidence of false thrombosis? I noticed that in your slides, if I correctly understood, you have 8% lung embolizations, pulmonary embolization.
So, so the trial required patients to remain on anticoagulation, and you raise an important point, and I think that is one of the limitations of valve replacement on the right side. I personally feel these patients are going to need to stay on lifelong anticoagulation. We've all had cases that, and the question is what type of anticoagulation? I've had patients, we don't have a lot of data with NOACs and DOACs, and we've had patients that are on NOACs that end up having halt. We switch to warfarin, it resolves. But anticoagulation is going to be a requirement for at least with the current designs for TTVR.
Please.
Thank you, Kodali-san. My name is Shirai from Japan. So, and now in the hospital, also participating in the TRISCEND trial, TRISCEND Japan trial. So, but the all of the candidate persons, among the candidate persons, only 50% is patient would be usually be passed because of the too large annulus and not much the devices and almost alley and alveoli distance is too small, too small. So it is not a candidate for the TRISCEND and evoke implantation. So how many percentages usually pass the criteria for evoke implantation in US?
It's hard. I think part of it has been evolving. The learning's been evolving. In this trial data that we presented thus far, there were only 3 sizes, but now we have a 56. So I think that, that initial screening, I believe like 30% was annular sizing, and I think those will be better. A lot of the pacemaker leads, there's some challenges, and I think we're understanding that we may be able to treat some of these patients. But some of the limitations in terms of, I don't remember the exact numbers, but severe RV dysfunction was another category that was eliminated. And I'd love to hear the panel's discussion. We don't even know how to measure true severe RV dysfunction. And so these sort of exclusions are evolving. I don't think it's 50% now. I think the exclusions are less, but we're still learning. The devices are going to iterate. Our understanding of the state's going to iterate. But there's going to be limitations because it's such a heterogeneous disease with a lot of different issues. And we've eliminated for severe pulmonary hypertension. So some of these clinical exclusions, we've excluded, but we still need to learn. And some of these patients may still benefit.
A lot of those exclusions were related to prior surgical predicates and probably reasonable at the start. I think it's a hard question to answer because what happened over the course of the trial was that we got much better at the sites of selecting patients out. We didn't even submit all the patients that we had. So the selection rate started going up significantly because we all knew that if you had a poor RV, you shouldn't bother even putting it in, or we could measure the annulus ourselves. So I think, Susheel, you can commiserate with that, right? Other questions?
Yeah, Bill, I have a question for any of the speakers. Is there any follow-up data on what happens to the need for diuretics in these patients after treatment with these modalities?
David?
It's a question that's been asked very commonly. The answer on the TRILUMINATE side is there were not big differences in diuretic dosing. There were small changes in the direction you would expect, less need in the TriClip treated patients, but they were not profound for that. I'm not aware if any of that information is available yet for TRISCEND.
Do you know about that in TRISCEND?
Not yet. Hopefully later this year.
Yeah, David and Susheel, one of the things that we'd love to see is mortality changes. David, I'm going to ask both of you to postulate as to, even in the early data you showed from the 1-year incomplete Evoke data, Susheel, there didn't appear to be an obvious mortality benefit, at least as yet. And the question is, why not? Is it too early? Are we just having too high an expectation that when RVs recover, we don't see a commensurate improvement in
I think,
mortality?
My own personal view is it's early, and we've made an unfortunate, an unfortunate decision in the way the studies were designed, that we allowed crossover at a year, which means that we will never have a very good measure of what happens beyond a year. Even in Evoke, where we've started to see some crossing, most of the patients are crossing over, and so we've kind of shot ourselves in the foot a little bit in impairing our ability to see the 1 year outcomes. I think again with Evoke, it's perhaps a little bit easier to understand because there were some early deaths in Evoke, so they started out kind of behind and have been catching up for the whole year with TRILUMINATE in the clip. There was no early penalty; there just wasn't a benefit, and so I think. I believe that there will be benefits long term, but we may never know. Unfortunately, again, I've been fairly vocal about this. I really wish that we didn't let the patients cross over at a year, but I didn't get a vote.
Susheel?
Yeah, and I think we did make some missteps. I think the crossover thing is a big component, and sort of related to that, we sort of screened out the sickest patients.
Yeah.
Right. Partner cohort B showed TAVR mortality benefit because all those patients were going to die at a year, 50% were. But if we enrolled patients anecdotally, the patient that was getting tapped every 2 days, every 2 weeks for ascites, that patient, when you did it, we've anecdotally had those patients that have gotten Evoke, they don't get tapped anymore and do better. Those are the ones that are going to show mortality benefit. But 30% of it is atrial functional TR. And I think we overestimated the mortality in that patient population. Their mortality rates at 1 year in atrial functional TR isn't going to be 30, 40%. So it's hard to show benefit if you only do a 1 year endpoint. So it's eliminating the sickest patients that may benefit and then not allowing longer term follow-up, I think is going to hurt us. But I think what we see here, that the data suggests both TRILUMINATE and TRISCEND eliminate TR is important to getting benefit. And the sicker the patients are, the more they're going to benefit. So a lot of what we got to learn, and we've made some missteps, but we have a lot of data that we're having from EFS and this, where we can learn who's going to benefit the most, and we can make educated decisions for our patients based on that. And that's really the ones that we're treating with Evoke right now, is the ones that are really sick, that we expect to get the most bang for our buck.
Yeah, I'm actually not an apologist for that. I think that we all see these patients in our office. They're living miserable lives, and the fact that we can help them basically go back to something that looks like a reasonable existence is to me worth whatever effort we put forward. So I have no problem with that, frankly, but I would love to see it, obviously.
Yeah, I think I think the point you're making is that mortality benefit isn't required in order to make this a worthwhile procedure. That these patients are sufficiently impaired, and the magnitude of improvements that we observe are, meaningful. And so, it would be a nice to have. It would be, it would help with the cost effectiveness or other sorts of considerations, and it would, embolden us, I think. But it's certainly not required to have a mortality benefit for a procedure like this to be beneficial.
I mean, the KCCQ improvements you showed, David, if you talk about heart failure, just plain old LV heart failure, interventions, those are significant.
Yeah, the benefit was seen with, TRILUMINATE of 10-point, absolute difference is that, absolutely meaningful. The difference that was seen in Evoke was a little bit larger, almost 15 points, because they started out a bit sicker, actually, in terms of their KCCQ scores. And that's, very similar to what we saw with MitraClip in the COAP trial. The difference being that, again, the mortality was much higher in the mitrals. And I think, the RV, for whatever reason, is a bit more tolerant of all these problems. Most of our patients die of LV problems before they die of RV problems.
David, I have a question for you about the KCCQ score. From your presentation, it seems very compelling that you see biological, improvement and it correlates with the symptom improvement. But it's not, what we saw like in the Relieve heart failure. There was absolutely no difference. But why is there such profound differences when using?
Yeah, I think.
Actually, the quote was KCCQ is dead.
That wasn't my quote. Whose quote was that?
I
Greg's.
think Greg said
Yeah,
that.
okay, Greg's.
I don't think, I think it's a little excessive, but what do you think?
Well, it's, I think if we do it again and we see results like that where the patients had marked reductions in hospitalizations without feeling better, then maybe it is dead for that condition, but I don't believe it. It's the only study I've ever seen where there was such a disconnect between the health status change and the clinical outcomes is Relieve HF. So if I'm as sort of somebody who's a reductionist by personality, my response is until that's replicated, I still believe the KCCQ more than one outlier study.
Did you have a question?
Yeah, so for those who are doing both, and if the patient is suitable for both the TEER or this, Evoke, which would you choose?
All right, for the three people who James, do you do it too?
Yeah, we do a lot of each.
What do you think?
Well, Susheel has mentioned that these patients generally require lifelong anticoagulation. So that's an issue. And David could tell you that anatomy really matters more so for TEER. So if you have poor TEER anatomy and you can tolerate anticoagulation, that might lean you towards valve replacement.
Susheel? We'll take a quick poll here.
Yeah, quick. It really depends on what kind of result I think I can get. If I have really favorable TEER anatomy, an atrial functional TR, I have a low threshold to do edge to edge. But if there's torrential TR and 5 leaflets, I'm not confident I'm going to get a good result. I lean towards replacement as long as I can anticoagulate the patient.
David?
I'm going to largely agree. Anatomy is going to dictate a lot, and NRV function are the two main parameters that we're going to look at. I think just given the incredible sort of safety of TEER, I think that you could put forward that should be perhaps the first line if you think you can get a good result, because again, of the tremendous safety record, but there aren't that many patients in whom you can get those exceptional results, and in those I think we have to be willing to go to a valve replacement technology, and fortunately we have one of those as well. But I do think again the anticoagulation is a barrier, and I really do worry in patients who have moderate to severe RV dysfunction that's I think we've all seen patients who get their tricuspid valve replaced, and then they really limp along for a period of time. Some of them even die from persistent RV dysfunction. So it's sobering when you see that you cured the disease you thought they had, but the problem really was an RV that was shot.
Yeah, I'm going to be even stronger. I think that TEER is my default strategy unless and until anatomy doesn't allow or dictate. And then in my situation, I would go to a replacement. I think the replacement, we're talking about 1-year data now. We don't know what the long-term failure rates are, and the person who made the low flow comment, I think, is correct. You're trading one disease for another, infection, thrombosis, failure, and so on. And so I think if we can repair a patient, and I would include cardioband in that assessment, assuming we can do it in less than 2 days. I think it would also be one of the ones that I would include in repair. Okay, this has been wonderful. Thank you to my co-moderator, to all the panelists. This is really terrific. Thanks to the audience for their attention during the session, and enjoy the rest of the afternoon.